Dr. Bryan and I are super excited to bring you the research that we're doing internally at the foundation. And I am excited to kick us off with our cost burden analysis for KCNT1. And I'm 100% certain that my family is happy that we are going to be done talking about the costs of medical things around the kitchen table. I am having trouble advancing my screen here. There we go. All right, as you might expect, KCNT1 related epilepsy results in significant healthcare costs, but the full economic burden has remained unclear. And so the rarity of this condition has led to limited documentation of our financial impact. We wanted to set out to do a comprehensive cost assessment, and this is essential so that we can illuminate the economic challenges faced by families and healthcare systems. And also, as we're going into clinical trial land, to inform the regulatory submissions for things like the FDA for disease-modifying therapies. So to do this, we had a couple different methods. We did a caregiver reported expense survey. We had 34 respondents from the community who participated in that. We also used electronic medical record data from the Citizen Health platform, which was really helpful. From there, we were able to map SNOMED codes, convert them to CPT codes, and determine the cost of each data point associated with our different categories. And the results are pretty conclusive. KCNT1 is expensive. In our parent reported data, we see that there are extremely high costs associated with hospitalizations, outpatient visits, therapies, such as physical therapy, occupational therapy, all the therapies, medication, emergency care, and the list goes on. There's also high costs associated with indirect medical care, such as families finding informal caregiving, respite care, things like that. And many of our parents reported loss of income due to the high demand of caregiving, where one or both parents could not continue in their positions because they're caring for their child. In this figure, you'll see, I'll direct your attention to the dark orange and red at the very top. So while we see high costs associated with medical appointments, hospitalizations, meds, everything before that really stacks up to be very expensive for the direct medical costs. Additionally, we have this graph showing annual non-medical costs. Specifically, and this was a little bit of a surprise, nutritional support, special equipment, and professional caregivers were among the highest reported. So then, continuing on with the expenses that don't end with KCNT1 epilepsy, when we extracted the data from Citizen Health, we looked at 34 patients over a 6-year span. We found out that the first year of diagnosis is really a doozy. There are so many high costs associated with diagnostic procedures, therapeutic procedures, hospitalizations, medications, and devices. However, we did see that these costs drop significantly in the second year after diagnosis, and we see hospitalizations across the board in all 6 years, making up the majority of expenses for patients. So here you'll see our 6 years. This is the average annual cost per patient. You can see the extreme burden that year one provides for patients that are recently diagnosed. We also see that the proportion of our other categories remain about the same in the years after that. So Brad and I want to acknowledge that we can only calculate the costs that we're given, and there are many costs that are hidden. And so we know and acknowledge that our numbers are going to be on the far low end for the burden of KCNT1 epilepsy. Also, we learned firsthand how extremely difficult it is to determine the cost of disease due to the complexities of our healthcare system. It was not easy to determine the baseline cost of many of these categories. We are in need of disease-modifying treatments because the current treatments are exceptionally expensive and they're not efficacious. And so we need disease-modifying medications quickly. And we'd also like to point out that the first year post-diagnosis is very crippling to families financially and logistically. If you can just imagine all of those hospitalizations and all of those data points that represent the burden of cost and time. So I think I'm going to kick it over to Dr. Bryan from here, and he's going to continue.
All right, thanks, Amanda, and we can have questions for both Amanda and myself at the end of the talk. But good morning, everyone. I'm Dr. Bryan. I'm the Director of Operations for the KCNT1 Epilepsy Foundation, and I'm happy to speak with you all today. A significant part of my role in the foundation involves data analysis, so I focus a lot on understanding data to improve the outcomes in the KCNT1 community. And in the realm of rare pediatric diseases, particularly like KCNT1 related epilepsy, we face some very unique challenges, and many of those we've talked about today. Many of our patients are young children, they're nonverbal, and they have significant communication impairments. And this necessitates a reliance on parent-reported outcomes, or I'll refer to them as PROs. And it helps us understand the needs of these children effectively. So what are parent-reported outcomes? Parents are often the first to notice any kind of subtle change in their child's behavior, their communication, their development, especially in children who are nonverbal, like most KCNT1 patients. And parents are really the primary observers of their child's daily experiences. So they notice these subtle changes, and changes that may not be evident in clinical settings in the 15 minutes a clinician may have to meet with a parent. So parent-reported outcomes, they're insights provided directly by parents or caregivers about their child. And their observations are especially crucial when the child's too young or nonverbal, like many of the majority of kiddos with KCNT1. And next slide, Amanda. In the context of drug development, especially for rare diseases, incorporating PROs is really essential. Regulatory bodies like the FDA or EMA, they increasingly recognize the importance of these outcomes in evaluating treatment efficacy. And by focusing on what really matters to patients and their families, pharma companies can help develop therapies that offer more meaningful improvements in quality of life, and they don't have to guess with what will be important and meaningful as an improvement. In today's competitive pharmaceutical landscape, companies, they also want outcomes that are meaningful to patients that can set their products apart. With KCNT1, we're all focused on reducing seizure counts, but reducing seizure counts in itself without a corresponding meaningful outcome in some aspect of the child's life that makes a difference, it won't truly benefit the patients and their families. So families really, they want to see tangible improvements, whether it's communication or less dependency on daily activity, on parents and caregivers for daily activities, or increased awareness. So pharma companies, they can really succeed, not just by treating symptoms, but also by highlighting the real world benefits their treatments offer. So next slide, Amanda. At our foundation, we think that families are at the heart of understanding KCNT1 related epilepsy. So that's why we really actively engage parents and caregivers to share parent-reported outcomes. And today, I'm going to share with you just a few minutes worth of some of the PROs that we've collected from the community. I hope the insights help you understand where the families are in their lives and their treatment and what needs are being addressed for them, and really what needs still need to be addressed. What you see on this screen and in the subsequent screens are a lot of data. It's a ton of data. We collect a lot of PROs from our community. And the data here is caregiver reported data. Essentially, it's asking parents to rate how important is some aspect, whether it's a developmental milestone or a treatment outcome, how important that is to them. And I don't expect you to go through all these data points, but I do want you to see that there's definitely trends that are reported by the parents. Anything you see in purple is an aspect that's really needed and wanted by the families. So to the right of the graph, you'll see that the families are almost unanimously expressing certain specific needs, like seizure control or basic communication. So if a pharma company develops a therapeutic that addresses one of these, one of the topics, let's say on the left side of the graph, say ability to self-soothe, that's a great improvement for some of our parents and patients, but it's less important for others and may not really address the most important needs of the families and the patients. Next slide, Amanda. So I'll sum up the graph really because it's a lot of tiny font, but I'll let you know what would be a good therapeutic outcome that helps meet parent needs. So what's good? Seizure control. Parents want that. They want overall health of their KCNT1 kiddo. And they want the ability to communicate basic needs. So we're not talking like advanced communication. We're like, I have pain, I have hunger, real basic communications. Less important to families are sleep. ability to follow directions, or managing different food textures. So for upcoming clinical trials, please note that seizure control or seizure counts, if your treatment can address those, then you can make the KCNT1 families very happy. Next slide, Amanda. Okay, so this slide, this is parent-reported data on how effectively their current treatment plan addresses those needs that they reported on the previous slide. And I'd say from this graph that current treatment plans aren't incredibly effective at addressing those needs. You certainly don't see as much purple on this graph. And almost all the aspects show about 40 to 50% of the participants indicated that their treatment plan either is not effective or only slightly effective. So we have a lot of room for improvement, and that means that even small improvements across these areas will be exponentially valuable to the families. Next slide. And what seems to be working in our treatment plan, and this is, this is all relative, but we seem to be able to decrease constipation. But one of the most important major parent needs, basic communication for pain, hunger, we don't address that. And that was something that was identified as a really high priority. And next slide. This will be my final data that I want to show. Finally, we can measure seizures or some other clinical outcome measure, but the reality is if a parent doesn't feel like the treatment's making their child better based on their needs, then is it really working in a way that benefits our families? So we ask parents what treatments they feel are working and which treatments aren't working well. We didn't ask specific questions like which interventions reduce seizures or which treatments allow them to sleep better, only which treatments work, period. And I recognize that working is a relative term because seizure control isn't something that we see in the KCNT1 community. But the data that we gain is still really interesting. And we see clear parent-reported trends on which drugs they feel are being used and which ones seem to be the most effective. Again, based on the parents' view of the world. If you switch to the next slide, Amanda, I'll show you the ones that really took to the top. And what works best on what the parents say, keto diet. Overwhelmingly, the keto diet seems to have the best seizure control. But clobazam, phenobarbital, Keppra, gabapentin, those as well. Epidiolex, not amazing seizure control, but it did actually show some seizure control. We talked a little bit about quinidine. Overwhelmingly, it didn't seem to have great seizure control, but in a real small portion of people, they reported that they saw some improvements. But again, as I said, improvements are very relative in the KCNT1 community because seizure control doesn't seem to be something that we can effectively do. So maybe there are other aspects of life that it's improving. So finally, last slide. In conclusion, parent-reported outcomes, they're really important for clinical care and for drug development because they help ensure that we address the real world needs and experiences of patients and their families. I'm a strong advocate for PROs, and I think utilizing the insights from these, we can help develop treatments that really make a difference in patients' lives. So thank you for your attention, and I'm happy for any questions. Also, if you have any questions for Amanda, we can take those all at this time. Thank you.
Thanks, Brad and Amanda. That was great. If anyone's got questions, we can do those now.
I think there was already, very powerful messages, very excellent data. I really appreciate what you've done. And I think there was already some discussion between David and myself in the chat on talking about benefit risk and how to bring this across also to stakeholders that are not so much present today. Which is probably regulators and also the payer community to make them understand what's really important in patients. So I really appreciate what you've done there. Thank you.
I've got a really quick question, just because I haven't even had a chance to see a lot of this data yet. The 34 patients that were surveyed, are those the same patients that you went and pulled the citizen data from?
Well, they were not the same patients because the data from the citizen health were de-identified, so we didn't know which ones that we had pulled.
How did you choose which patients from the citizen cohort?
We looked at the whole thing. So we showed the data here from 0 to 6 because it was probably the most clear trend. The data gets a little wonky as you get further on because you get less patient numbers, and so you can maybe take that a little less confidently. But from 0 to 6, we had really good numbers. And then the other data that we showed was largely just polling the community. So we had our own internal registries that that we've asked questions on. The financial analysis was we did poll the U.S. community because we wanted to use U.S. dollars, and our healthcare system tends to be a little different than other countries. But yeah, I mean, just asking parents, and there's artificialities and all that. The EMR data is missing stuff. Parents may underestimate or overestimate, and so that's why you use that balance of both, so that you can try to get some idea of reality.
Was everyone an EIMFS patient, or did you also have some SHE patients in this?
We had both, overwhelmingly EIMFS.